Good morning, good afternoon, and good evening. Thank you for joining the Wilson Center along with March of Dimes, the University of Pittsburgh, and the Jonas Salk Legacy Foundation for this panel discussion on rolling out a COVID-19 vaccine, present prospects, and lessons from the past. I'm Sarah Barnes, and I direct the Maternal Health Initiative at the Wilson Center in Washington, D.C. For those of you who are unfamiliar, the Wilson Center is a living memorial to President Woodrow Wilson, who remains the only president to have earned a PhD. Congress decided to honor his legacy with a think tank in his name. 50 years later, the Wilson Center remains a critical source of nonpartisan foreign policy research and analyses and is ranked as a top 10 think tank in the world. The Maternal Health Initiative is one of several thematic programs at the center, and we focus on decreasing maternal deaths as well as issues related to global health and gender equity. The COVID-19 pandemic intersects every aspect of our work at MHI. As of today, globally, there are more than 38 million confirmed cases and more than 1 million deaths in 198 countries attributed to COVID-19. As the number of cases and deaths continue to rise, there's an increasingly urgent need for a vaccine. While historically vaccines take years of research and testing before being rolled out to the public, the prior record was 4 years for the mumps vaccine. The urgency of COVID-19 has pushed scientists to compress this process as much as possible while still preserving the safety and effectiveness of the vaccine. In the race to meet this urgent need and to address these concerns, it is crucial to learn from previous vaccine efforts to safely and ethically develop and effectively distribute the COVID-19 vaccine. 65 years ago, Dr. Jonas Salk and his team of scientists at the University of Pittsburgh, with support from March of Dimes, developed the first safe and effective vaccine against polio. Today, these partners are back together, this time with Dr. Jonas Salk's son, Dr. Peter Salk, to discuss the ongoing COVID-19 vaccine development, current challenges and public trust in the process, lessons from previous vaccine development efforts, and questions about safe and equitable distribution, availability, access, and uptake. I'd like to take a moment to thank March of Dimes, the University of Pittsburgh, and the Jonas Salk Legacy Foundation for your partnership and support in coordinating this event. Thank you also to our group of eminent speakers and panelists and our guest moderator for being here with us today and tackling this ever-evolving conversation around a COVID-19 vaccine. I'd also like to thank my MHI colleagues and our great Wilson Center AV team for their work on this event. And before I hand this over to our moderator, just a little bit of housekeeping. I want to remind our audience that there will be an audience-led Q&A following the panelist discussion. So please submit questions to MHI, as in Maternal Health Initiative, just the 3 letters, MHI@wilsoncenter.org. My colleagues and I will review the questions and share them during the Q&A. Please include your name and affiliation, and this email address is also listed on your invitation. You can also follow the conversation on Twitter @Wilson_MHI using hashtag COVID-19 vaccine or hashtag vaccines work or hashtag MH dialogue. It is now my pleasure to introduce our moderator for today's discussion, Chris Adams. Chris is the Director of Training and Content at the National Press Foundation, where he runs fellowship programs for working journalists. He is also an adjunct professor of journalism at American University. He was previously a political and investigative reporter for the Wall Street Journal, McClatchy, Washington Bureau, and other news organizations. We're so honored to have you here with us today, Chris. I turn things over to you. Thank you very much.
Thank you very much, Sarah. As Sarah said, I'm from the National Press Foundation, and my normal role is training journalists on important topics. We've done a couple of programs on vaccines in the last 2 years. The one in 2019 was a good program, but it seemed very calm and quiet. No real sense of urgency, just a few scattered measles outbreaks here and there to talk about. The one we held this summer just a couple months ago was nothing but urgency. And we're gonna be covering a lot of those same issues in our program today. We will be hearing from 6 outstanding medical leaders, and then we will have time for questions, as Sarah mentioned. One more time, I'd like to give you the email and our hashtags. email questions to mhi@wilsoncenter.org and indicate your name and affiliation. Follow us on Twitter at Wilson_MHI. The hashtags for today are COVID-19 vaccine, MH dialogue, and vaccines work. We'll hear first from Dr. Peter Salk and then have a panel with 4 top experts and then go to questions from you and from me. And we'll have closing remarks from Dr. Anantha Shaker of the University of Pittsburgh. So for starters, we are thrilled to have with us Dr. Peter Salk, president of the Jonas Salk Legacy Foundation in La Jolla, California, and professor in the Department of Infectious Diseases and Microbiology at the University of Pittsburgh's Graduate School of Public Health. He worked with his father, the legendary Jonas Salk, at the Salk Institute for Biological Studies on immune-based interventions for cancer and multiple sclerosis, on improvements in vaccine production and methodologies for polio and other diseases, and on an experimental vaccine for HIV/AIDS. He's going to talk about the current vaccine development process. So Dr. Salk, welcome, and we're very looking forward to your talk.
Great. Thank you very much, Chris. And I just want to say that it's a pleasure to be here and to make some remarks about what happened back in the 1950s, when my father and his research team at the University of Pittsburgh developed the first successful polio vaccine. A great fear was lifted. In this country, as well as around the world, epidemics of polio were ravaging communities. Parents were terrified. Everyone wanted to have something. This went on for decades. In this country, there were about 58,000 cases of polio at its peak in 1952, and around the world, about 600,000 cases of polio. My father and his team took great care to be sure that the vaccine that they turned out would be safe. It started with dangerous live poliovirus that was inactivated by a chemical, and all of the conditions were set so that it could reproducibly be a safe vaccine. Nevertheless, once the vaccine moved into a commercial production phase and the government took over responsibility for the monitoring of the production and testing, a huge mistake took place. One of the new manufacturers that came on board did not pay adequate attention to the procedures that had been outlined, and kids were injected very shortly after the vaccine was approved with batches that contained live poliovirus. As a result, there were 159 individuals that were left paralyzed and 10 people died. This was a great tragedy. The procedures were put into place by the government to ensure that that would never happen again, and it did not. And those procedures are still in place to make sure of the safety of new vaccines as they come along. But even carefully prepared vaccines can have problems. There are times when you can't predict what the outcome will be. And on occasion in the past, vaccines that looked as though they should be promising turned out to make matters worse once people who had been immunized were infected. So it's really important that with the coronavirus vaccines that are in research stages right now, that corners not be cut, that all attempts be made to be sure that these vaccines are going to be safe when they begin to be applied. And in some cases, one has to just continue to monitor carefully to be sure that things are going to stay on track the way one wants. It's vitally important that as this vaccine, either the first vaccine or successive vaccines get rolled out, that they be available where needed, where people want them and where the epidemic is particularly severe. And in terms of subgroups of the population, such as in this country, the Black population, Hispanic population, Native American population, which is being hit extra hard, we have to be sure that vaccine is appropriately available so that it can be used effectively. So what's important also is that whatever fears there might be about vaccines, that they be handled appropriately, because vaccines, when appropriately managed, will be safe and can be extremely effective. So we have to be sure that enough people will end up being able to have access, that the level of immunity in the population is high enough to blunt the continued spread of this very devastating coronavirus. with respect to polio, we're on the verge of getting close to eradicating this disease globally through a global effort, and the prospects exist that we could, at some point in the foreseeable future, begin to relax ourselves about this current coronavirus epidemic. I want to express my thanks to those people we are working with. All of this started when Dr. Gupta, whom you'll meet in a moment, called me back in May and suggested some collaborative activities around coronavirus. And that because this year is the 25th anniversary of my father's death, it struck me that this might be a route that would be meaningful to have this kind of collaborative interaction and to bring again together this group of related to my father, the University of Pittsburgh, and the March of Dimes, which made that polio vaccine work possible. So thanks very much, and I'm very much looking forward to the discussion that will follow.
So thank you very much, Dr. Salk. It's a fascinating legacy that you're involved with, and we're looking forward to having you here with our program today. So as I said, we have a panel discussion, 4 panelists, and then afterwards we have closing remarks. Our panelists, I'm just going to give you their names and their affiliations, and when each one of them comes up, I'll give you a little more detail on their background. But we'll have Dr. Paul Dupre of the University of Pittsburgh, Dr. Ruth Karen of Johns Hopkins University, Dr. Rahul Gupta of the March of Dimes, and Dr. Lisa Waddell of the CDC Foundation. They'll be talking about public health implications of the vaccine development with the global health focus, population and disparity issues such as with pregnant women, Black Americans, Native Americans, children, and regulatory aspects of the vaccine. They'll all also be talking about vaccine hesitancy, which we know is going to be a major thing to deal with in the coming months. So our first talk today is from Dr. Paul Dupre. Dr. Dupre is the Jonas Salk Chair for Vaccine Research at the University of Pittsburgh, and he leads Pitt's Center for Vaccine Research. He directs Pitt's Regional Biocontainment Laboratory, a high-security facility embedded in the Center for Vaccine Research that allows scientists to safely contain and examine potentially dangerous pathogens. Currently, he and his team are in the process of researching and developing a COVID-19 vaccine, and he is going to be talking about those efforts and other development efforts right now. So Paul, welcome. And he has a slideshow, and so we're looking forward to this. So to you, Dr. Dupre.
Well, it really is an honor for me to follow Peter Salk and show a photograph of his father that I walk past often in the Center for Vaccine Research. And what's important to remember from this slide, and what I want you to take home, is Pittsburgh still, after 65 years, does vaccines. From poliovirus that we've been talking about already to SARS coronavirus. And what you see on the left is the black and white image of the past, but the current image of the future, a little bit more colorful. One of our staff working hard on coronavirus, which we got in the early stages of the infection. So really, vaccines run through the veins of the University of Pittsburgh, and actually the city of Pittsburgh as well. Whenever we talk about coronavirus, we need to do a little bit of a deeper dive into the virus. And whenever you see these cartoons on the television, this is the type of image that you see. And really what I want you to take from this slide is it's all about the spike. These proteins which stick out of the surface of this virus, the spike protein which leads to the generation of antibodies. And these antibodies are known to neutralize, reduce the level of infection of the virus. That's the natural process when you get the disease. But of course, whenever we want to generate vaccines, we want to mimic that natural process, not with the actual virus, but with the vaccine. And those are the types of new modalities that I'm going to just bring us through briefly, just to set the tone for our conversation so that we know what we're working against and what we're working on. So it's all about the spike and making antibodies to it. Creative vaccinology. In 2020, we can make vaccines in ways that Jonas Salk could really only have dreamed about whenever he was inactivating chemically poliovirus in the 1950s. You will have heard about DNA vaccines, RNA vaccines, protein vaccines. Actually, that's what an inactivated virus is. It just is a protein which allows the immune response to be trained to make these important antibodies which protect against the disease. If you meet the disease, when you're on the bus, when you're walking down the street, wherever you happen to be. So this is the science that's going on at the moment. New ways to make vaccines, but all of the roads leading to the generation of something which looks like the SARS coronavirus spike, but is not the SARS coronavirus. Training the immune system to make antibodies in the absence of generation of disease. So even though Jonas Salk could have only dreamed of what was going on at the moment, this process for him would be very, very familiar. The idea of generating antibodies, for him it was poliovirus. For the world at the moment, for the COVID-19 vaccines we're discussing, it's SARS coronavirus 2. Of course, there are not only DNA, RNA, and protein ways that we can train the immune system, but these are three other ways in which novel, creative coronavirus vaccines are being generated. We take an adenovirus and we insert the genetic material of that spike. Once that adenovirus infects a person who is vaccinated, that spike protein is produced. We make a virus like vesicular stomatitis virus coated on the outside of that bullet-shaped particle that you're seeing, coated with the spike proteins. And in Pittsburgh, we're working on recombinant genetically engineered measles viruses, a wonderful vaccine platform which can be retuned and retooled to produce the spike protein. What we're doing is we're injecting all of these different novel vaccines into individuals in phase 1, phase 2, phase 3 trials. And you'll hear about that process from one of our next speakers. But what we're also doing is we're seeing a new range of individuals, companies who have never made vaccines before, companies who have a phenomenal track record in vaccine development, companies in America, in Europe, in India, for example, the Serum Institute of India, one of the companies which makes the vaccines which are used to vaccinate over 2/3 of the world's children. So it's a novel way to make vaccines, and it is a global enterprise to generate these vaccines. In our introductory remarks, you would have heard the word race. Yes, indeed, it is a race, but it also isn't a race. What we know is vaccines are slow. What we will discuss today is, yes, we are pushing the vaccine development process through the pipeline fast. But what we will not do and what we cannot do is rush that development process. From the creativity of the preclinical research in laboratories and centers like mine all over the world, to the companies that we've just talked about who translate those ideas, who take those ideas and turn them into products. And what's also important, and again, we'll discuss that later, first may not be best, which is why, yes, it's a race. Yes, competing in that race is super important. Yes, it is vital that we have a wide range of different developmental vaccines for COVID to use, because we don't know what is in front of us and which ones will work best. Finally, it's not a vaccine until it's a product. And vaccines are not products of 1 or 2 or 10 or even thousands. vaccines are required in hundreds of millions of doses. And that's why it's very important at this stage in the process to partner with companies who have the machinery in place to fill these vials and distribute these vaccines all around the world. What we need to do is develop vaccines not just for our part of the world, but for all of the world, because everyone across the world has equal meaning and equal value and equal worth. And we need to ensure that those vaccines are developed for all. So finally, bridges, not bubbles. What does that mean? Well, Pittsburgh is a city of bridges. Collaboration is critical. Building bridges between groups across nations is vital. Healthy competition is good because competition drives innovation. But we should never look beyond the idea that this needs to be for the good of public health, not just public health in Pittsburgh or public health in the United States, but global public health. So I hope these introductory remarks have set the scene, given us an idea of the vaccines that we're working on and where we want to go, and that vision for creative vaccinology. Thank you very much.
Okay, Paul, thank you very much. It's nice seeing this image of Pittsburgh. I used to live and work there, so I can actually see my old building in that little that animation shot you had. So thank you very much. And now we're going to go on to Dr. Ruth Karen, who is going to talk more about the development and the regulatory process. Dr. Karen is a professor of international health in the Bloomberg School of Public Health with a joint appointment in the Department of Pediatrics in the School of Medicine at Johns Hopkins University. She is a pediatric infectious diseases physician, a virologist, and a vaccinologist, and is director of the Center for Immunization Research and the Johns Hopkins Vaccine Initiative. She's also played an important role in committees that advise the FDA and the CDC on vaccine approvals. So Ruth, we're very much looking forward to your talk, and I'll turn it over to you now.
Thank you so much, Chris, and hello, everyone. I also want to thank the Wilson Center and the University of Pittsburgh March of Dimes and Salk Legacy Foundation for inviting me to join you today. I'd like to speak to all of you about critical issues that we're facing in COVID-19 vaccine evaluation and regulatory decision-making. As of today, the United States leads the world in COVID-19 cases and deaths, and also has one of the world's highest COVID-19 associated death rates. In our failure to adhere to basic public health principles, we have, in the words of the editors of the New England Journal of Medicine, taken a crisis and turned it into a tragedy. However, we now have an opportunity to lead in a way that benefits people in our country and all over the world, which is to use the best possible science to guide the evaluation, regulation, and deployment of COVID-19 vaccines. Our government has supported the development of a portfolio of vaccines based on a number of platforms. Several vaccines are in late-stage clinical trials, with trials of additional vaccines planned in the coming months. These trials draw upon the expertise of academic investigators and clinical trials networks that have been developed and supported by the US government for years. Manufacturing of these vaccines is also underway to support deployment if they are shown to be safe and effective. Safety and efficacy data from these trials will be evaluated by highly experienced career scientists at the FDA, using criteria that were clearly articulated in an FDA guidance document for COVID-19 vaccine licensure, and more recently in a guidance document for emergency use authorization, EUA, of COVID-19 vaccines. These data will also be presented publicly and discussed by the Vaccines and Related Biologic Products Advisory Committee, Verpac, an independent group of experts that advises the FDA on vaccine licensure, and in this case, potentially on EUAs. For COVID-19 vaccines that are authorized or licensed, ACIP, the Advisory Committee on Immunization Practices, can advise the CDC on vaccine allocation and prioritization, drawing upon the framework for equitable allocation of vaccine for the novel coronavirus recently published by the National Academies of Science, Engineering, and Medicine. We have all of the building blocks to support and sustain rigorous, careful, and ethical evaluation, regulation, and deployment of COVID-19 vaccines, as long as we don't allow political considerations to derail the process. Harnessing the best possible science also means that the information about vaccine safety and efficacy that's reviewed by FDA, Verpac, and other advisory committees is representative of our society, which means that trials must include volunteers from diverse racial, ethnic, geographic, and age groups. We need to know if these vaccines are safe and if they work in each of these groups, which will lay the foundation for equitable access and for widespread acceptance and uptake. Substantial efforts have been made by companies, by clinical investigators, and most critically, by members of underrepresented communities to increase trial participation and build trust. These efforts will need to be sustained as COVID-19 vaccine trials continue and new phase 3 trials begin. We also need to devise a clear plan to meet the needs of pregnant women. Reports indicate that pregnant women, particularly Black and Latina women, may be at increased risk for hospitalization and ICU admission compared to their non-pregnant counterparts. Moreover, many pregnant women suffer from comorbidities such as obesity, diabetes, and hypertension, which are known to increase the risk for severe COVID disease. Pregnant women are high-risk healthcare workers and first responders, the group proposed for phase 1 allocation by the National Academies, and they are also members of every category proposed as phase 2 by the Academies. If we don't yet have data from carefully conducted trials that deliberately include pregnant women, we will need a plan to protect pregnant women in these priority groups when vaccine becomes available late this year or early next year. If vaccines are not recommended, other strategies for minimizing workplace risk must be developed and implemented. The coming weeks and months will be critical for rational, science-based decision-making about COVID-19 vaccine authorization, licensure, and allocation. Our leadership in this and our collaboration with colleagues, governments, and non-governmental organizations around the globe who are also working to develop and deploy COVID-19 vaccines is essential. Thank you, and I look forward to your questions.
All right, thank you very much, Ruth. So we are going to turn next to Rahul Gupta, who is going to talk about the public health mandate and distribution issues, supply chain issues. Dr. Rahul Gupta is the Senior Vice President and Chief Medical and Health Officer of March of Dimes. He's a practicing internist with 25 years of clinical experience, and he also serves as faculty at Georgetown University School of Medicine, West Virginia University School of Public Health, and the Harvard University T.H. Chan School of Public Health. He was also a state public health commissioner in West Virginia, and in the 1990s, he helped launch the first pulse polio campaign in Delhi, vaccinating over 2 million children in one day. So Rahul, we're very much forward to looking to your talk about what the public health community and infrastructure will be doing to help roll out the vaccine once it is made available. So Rahul.
Thank you, Chris, and thank you to the Wilson Center, as well as my colleagues here for discussing this very important issue. It's very essential for us to really look at, as we've heard about and learned about, the vaccine development process, perhaps the regulatory process. You know, there are about 187 various COVID-19 vaccine candidates across the globe, whether in preclinical development or undergoing clinical trials right now. As one or more vaccine gets approved over the next 3 to 6 months, it's very unlikely that sufficient quantities of the vaccine will be immediately available for us to vaccinate large portions of the United States, much less the globe. So it becomes very important for us, an issue of distribution of the initial limited supply in a manner that is evidence-based and equitable, and a manner that leads to actually building of the trust across the nation, something what we are currently lacking And that is a challenge that is growing by the day. As my colleague, Dr. Karen mentioned, the National Academies has recently provided us a report as a roadmap in the development of a plan for national local health departments, as well as other public sector partners, to work with private sector partners in the allocation of the vaccine. So I'm going to go through a little bit, expand a little bit of what Ruth had just mentioned to just give people a flavor. But it's very important at the same time to understand that the equitable nature is so critical in the distribution and allocation of the vaccine that we must make it front and center of any campaign. We also must recognize that there is a declining confidence in a safe and effective vaccine, and thus we must consider launching as soon as possible, even prior to the availability widely of a vaccine, COVID-19 vaccine promotion campaign that is done by trusted partners across the country and is apolitical in nature. So let's imagine how this would work once we have a safe and effective vaccine. As we experienced in the 2009 H1N1 global pandemic, where I was serving as a local health official, we can expect that the initial period when the vaccine demand exceeds supply, there will need to be recommendations to provide vaccine to the high-risk groups first. What does that mean? Well, the National Academies has developed some foundational principles that we must maximize, through which the societal benefits, as well as those that are aimed to initially reducing the significant both case counts as well as the deaths and complications that are occurring as a result of transmission of this virus. So the first phase may include a percentage of the population that includes the frontline health workers. And as Ruth mentioned, many of those are already people with high-risk conditions, including those who are pregnant as well as lactating. These people also could be included as well as those transportation environmental services workers who are also exposed to bodily fluids or aerosols, public health workers, first responders. The next would also include those folks who are at significantly high risk as defined by the CDC. These are the Americans across the nation that are older than 65 usually, but they're living in congregate settings or overcrowded settings, in addition to those who are suffering from serious medical conditions or chronic conditions that are already at high risk. That includes people with serious heart conditions, cancer, diabetes, lung conditions. It's also important that next phase two, would be a group of people who are more moderately high risk. This is where, as has been mentioned, would be pregnant people, but also would include teachers, K through 12 teachers, school staff, child care workers that play important roles in the child's education development. So we could begin, phase opening back of our schools and the systems in our society can start to go back. So this also includes people like workers in food supply systems and public transit. The idea of phase two will be to ensure that people who are able to begin and open up our economy are actually being able to do so. We also must include in this phase people who are homeless or are in homeless shelters or group homes, people who have disabilities, and those who are in recovery. It's important to also include in this group underserved population who are also often overlooked. These includes people in prisons, jails, and detention centers, and staff that is tending to those folks. I think the last, before we get to covering everyone, the last phase of that, prior to that, would be population of young adults, children, and workers in industries such as colleges, universities, hotels, banks, exercise facilities, and factories. If we were to follow this mechanism that's broadly been laid out by the National Academies, we would be able to actually follow an evidence-based approach to achieving outcomes, and actually the most accelerated and aligned way of getting to where we have to. It's also important for us that we continue to monitor not just the vaccine and its distribution. CDC has one of the best partnerships and historical aspects of working with local and state health departments. but also supplies like syringes, vials, stoppers, alcohol swabs, Band-Aid, sharp containers. These all become critical. So it's also important to keep an eye on that. And just know that building trust will be critical as we launch the vaccination campaign. To build the trust in the vaccine begins much earlier than that. So with that, I'll close my comments. Thank you.
Okay, Rahul, thank you very much. And finally, the last of our panelists, and then I'll have some questions for them all, and then we'll start taking questions from our viewers. We will have Dr. Lisa Waddell. She's the Chief Medical Officer for the CDC Foundation, where she manages COVID-19 response efforts, including directing the Foundation's team of senior advisors providing support to the public health systems across the nation. She also helps direct the COVID-19 core surge staff hired to provide direct support in health departments across 64 state, territorial, local, and tribal jurisdictions nationwide. She's going to be talking about COVID-19 disparities, both what that means for vaccine, for diagnosis, and for vaccine uptake, and who the trusted messengers are for various communities. So Lisa, I want to welcome you and look forward to your talk.
Good morning. Hello to everyone, to my distinguished colleagues on this panel, to the team at the Wilson Center, and to all of you participating today. Again, good morning. It is indeed an honor for me on behalf of the CDC Foundation to join all of you here today. The CDC Foundation is a nonprofit organization. Our vision is to save and improve lives by unleashing the power of collaboration. And certainly today's event is an example of collaboration. We work to support CDC to do more faster by forging effective partnerships to fight threats to health and safety domestically and internationally. And we, like many others, have been actively working and supporting efforts to address this pandemic since the very beginning. We provided tons of support thanks to the generous support of donors. We've distributed PPE, lab and medical equipment, supported testing, hiring 900 surge staff for health departments, supporting national campaigns, community-based organizations, and supporting important research, including the priorities study, Dr. Gupta. This is a historic time for our country and our world. The novel coronavirus is the greatest threat of our time to our health and the global economy. It's a historic time for our families and our communities, for our frontline public health and healthcare workers. It is a historic time for our scientists and our researchers, for our businesses, public and private, for our local and public and national public health system. It's a historic time for policymakers at all levels to really peel back the onion and examine and address the underlying issues that are unfolding right in front of us, and quite frankly, what continue to contribute to the issue of trust that Dr. Gupta has already mentioned. If there was ever a time for collaboration, partnership, and understanding and embracing that together our impact is greater, now is the time. You all know the story. You hear the numbers, the tragic numbers every single day. Over 7.9 million cases in the US, more than any other country. Over 216,000 deaths to our fellow Americans here in this country. And cases and hospitalization rates are on the rise yet again. Sadly, we have experienced personally or read about the people, the mothers and the fathers, the sons and the daughters, the teachers, the healthcare providers, and many others who have lost their lives to this deadly virus. In fact, a 28-year-old teacher who taught at the school that my sons went to in elementary actually was one of these sad, tragic numbers. So number one, we should absolutely be outraged. We cannot let this time in history end without meaningful and systemic changes to address the underlying inequities that have and continue to define this pandemic. Health inequities are avoidable, unfair, and unjust differences in health. And this is abundantly evident in what we have seen unfold with COVID in our country. The data clearly shows that COVID-19 mortality rates are more than twice as high in Black, Latinx, and Indigenous populations compared to white populations. And nationally, Black Americans account for 13% of the US population, but 24% of the coronavirus deaths for which we have the racial and ethnic information available. And in some states, we all know it's much worse. And in some states, the Black share of COVID-19 deaths exceed the Black share of the population. Outrageous. There are a number of reasons that this may be the case, including pre-existing health conditions, but the underlying social factors, the issues around crowding, multi-housing conditions, and longstanding policies that simply contribute to health inequities. So number two, we know that there are barriers to accessing care and to accessing vaccines. So as we anticipate the availability of a vaccine to protect against this deadly virus, it is incumbent upon us to identify and acknowledge the barriers and concerns about a new vaccine. The reality is that the World Organization ranks vaccine hesitancy as one of the top 10 global threats to global health. So we know that there are real concerns about vaccines. And the relatively low uptake of the annual flu vaccine each year is, quite frankly, a signal toward the ongoing challenges that we have with adult vaccinations. But hesitancy is not the only barrier. There are those who may not have access to the vaccine. They may not have insurance, or their insurance may not cover the vaccine. This pandemic reminds us that policy plays an integral role in how individuals and communities respond to recommended actions. This is where not acknowledging and addressing those underlying social determinants of health and the structural and systemic policies that are in place, in fact, do make a difference. While we may say, yes, go get your flu vaccine, yes, go get your COVID vaccine, but if my job is one in which I must go to work and I'm afraid that I'm going to lose my pay and my job, then what are the policies? What are the systemic structures that are in place that are creating a barrier to me actually doing that? Data from a recent Pew Research study indicate, again, that little over half of Black adults say that they would definitely or probably get a coronavirus vaccine if one is available, while 44% actually say they would not. I actually think that's probably pretty generous given the actual practice that we see with flu vaccines. Hispanic and white adults are far more likely to say that they would get a vaccine. And additionally, we also know that Blacks have overall a less positive view of medical scientists than Hispanic and white adults. It's all about trust. It's so much about history. So what do? We know that there are real and perceived barriers to vaccines. So how do we get that message out? How will we help Americans, and particularly vulnerable, underrepresented communities, be willing to accept the vaccine? Assuming that we have a vaccine, and certainly that's what we're all planning for, the success of actually getting that vaccine into the population will ultimately rest on the public's acceptability of the vaccine. And during times of crisis, as we've already heard, the situation is often uncertain, information changes as more is learned, and the situation can become politicized. The job of scientists and public health professionals can certainly be challenging. So we have to rely on trusted messengers. We need to ensure that we are working with communities of color and that we have effective communication strategies in place to overcome those barriers. We must engage providers and healthcare professionals. We need to ensure that the insurance providers make sure the vaccine is available at no cost to overcome barriers, and that those who don't have insurance will have access to the vaccine. And we must ensure that communications are developed with the input of engaged communities and developed by persons who they trust, like their physicians who look like them, that live in their communities, and that we collaborate with other partners like the faith communities and others. We learned a lot through HIV with all of this, and we've learned a lot through the challenges with flu campaigns, and we need to translate that to this. We have to fully leverage the power of collaboration and working with businesses, both large and small corporations. So in summary, it's an historic time in our country The pandemic is deadly and has exacerbated and laid bare significant inequities. But we must work using these trusted messengers in communities to harness the power of well-designed and implemented communication strategies that are culturally appropriate, recognizing language differences and community perspectives in order to overcome the barriers around trust that we know exist and the barriers around policies that must be addressed. Together, our impact is greater. Thank you.
So thank you very much, Lisa. For starters, I, as the moderator, would like to thank, we have had 5 speakers so far and everybody's come in within their allotted time. So thank you very much, makes my life a lot easier. But it is 10:45 Eastern time right now. This program goes until 11:30. I have some questions and then we have time for questions from our viewers. So we've had some questions coming in. Keep sending those in and I'll work those into the conversation over the next 45 minutes. But for starters, I want to ask a question about something that Lisa was teeing us up for, and that's vaccine hesitancy. So right now we're talking about a race to a vaccine and the plans to deploy it, but what if few people take it? There was a Wall Street Journal NBC poll that was just put out yesterday that said only 70% of registered voters said they would take one, and most of those said they would wait for a while. Only 20% of respondents said they would be first in line to take a vaccine. Other polls have shown even more resistance, sometimes down to the 50 or 55% mark of people who are willing to take the vaccine. So I'd like each of you to talk to me about vaccine hesitancy, starting with Rahul. What are some of the, is there any way around the hesitancy that we know is out there that it seems to be growing as opposed to receding? So we'll start with you, Rahul.
Thank you, Chris. Vaccine hesitancy is to be expected in a normal circumstances. It's very different from being what we call "quote unquote" anti-vaccine. It is normal for average citizens and residents to be questioning the vaccine before they take it into their bodies. That's where the transparency of the manufacturing process, the regulatory process, and building trust in that system is so critical and important. It is not wrong at all to be hesitant. What is important is to demand that we have a safe and effective vaccine. We also need to understand that it is these days in the polarized and divided world, it's very easy, whether we see it with masks, with social distancing, other aspects, to view vaccines from a political lens. So it's very important that we understand that vaccines are some of the most investigated, documented safety countermeasures and drugs out there of anything. We do also have a very safe, advanced mechanism to capture safety side of this. But I will be really clear. When we, Dr. Salk and Dr. Francis conducted a trial back in 1954 and 1955 with the vaccine, there were 1.8 million participants to the vaccine. We have thousands, in some places, tens of thousands of participants in each of these clinical trials enrolled. So there is no doubt in my mind that when we take and extrapolate the results from thousands or tens of thousands to hundreds of millions and sometimes billions of people, some side effects will come out. We saw that with the H1N1 vaccine, which may not have been previously documented. That is not a reason to doubt the safety and efficacy of vaccine. That's a reason to have a robust process to be able to discover that, make the appropriate changes, and to do that, what we need is a trust of people in the systems of manufacturing, and then we need policymakers and other officials not to politicize this process and to trust in science and trust in evidence in order to have success.
Okay, I want to pick up on that and go back to Lisa for more on trust. Lisa, say that everybody in the federal, state, and local governments got on the same page and channeled Dr. Fauci, for example, of the NIAID, and spoke with a uniform message about the development, the approval of, and the need to take the vaccine. Republicans and Democrats, federal and local folks, we're all talking from the same page. Would the public come around? Would we see those numbers go up, or people, is it like so many other issues right now, people are kind of stuck in their viewpoints?
Thank you, Chris. So leadership matters. leadership matters, and it's important to model the way. And so similar with mask, we've seen that with mask requirements that people tend to follow that. And when they see their leadership doing that, then people tend to follow. And so if we go into schools and the teachers are wearing their mask, their students are going to generally wear their mask. If you go into your other kinds of institutions and everyone are wearing masks, and then others are going to wear their designer, fancy football, whatever types of masks. So leadership matters. And so if we have a consistency in messaging around the vaccine, and everyone is actually sharing that message, then yes, it's going to build trust. But it still it's important that we communicate early, we communicate often, we repeat those messages, and that they are delivered in a lot of different ways because people receive information in different ways. And then ultimately, it still matters about who the messenger is. So the messenger needs to be from individuals in the communities where people live, that they tend to listen to them as respected leaders. And so that's why it's so important to partner with many others in communities, particularly providers. Healthcare providers will be really important early on, that they believe in the vaccine, they understand they are communicating as trusted, respected leaders in their communities. And then over time, we will see improvements, I believe.
Okay, so I'd like to hear, Paul, I mean, what thoughts do you have on vaccine hesitancy, either how it's built or what can be done to mitigate it?
So I think it's important to reiterate that point, that it is understandable and it is not wrong to be hesitant. It is good to ask questions, and it is good and important to have trusted messengers in front of you who can answer the questions, who can relate, who can communicate. And that's why communication, collaboration, transparency, partnerships, right from the beginning of vaccine development through these faces that you see in front of you now, a group of individuals that span from molecule right to the person, the man, the woman who will get the vaccine. So firstly, I think it's important to consider that. Secondly, it's important to remember that we need to champion these products. We need to show what they have done in the past. That's why I think it's wonderful to have discussed polio virus today, pushed to the edge of eradication by safe, efficacious vaccines. I have worked with measles for the entirety of my professional life. And I have seen in the United Kingdom, when unsubstantiated, unfounded associations between measles and autism, measles and Crohn's, measles and this plethora of different unsubstantiated associations, I have seen the vaccine uptake reduced from 95% to 74%. And again, I started this conversation talking about the basic science. I'm a virologist. And the sad part of that is there are viruses in my freezers that have made their way to the University of Pittsburgh from Belfast to Boston, from Boston to Pittsburgh, that come from the brain of a small child who was not vaccinated for measles. So as Lisa personalized what happens whenever you meet a virus, as I have with her 28-year-old teacher who is no longer with us for her kids, as I have personalized a virus in a freezer which came from a person who is no longer with us, I think we have to remember not to forget. not to forget what these diseases did in the past, and to actively collaborate, to work with each other, and to communicate well that vaccines work.
Okay, and I just want to hear from Ruth on the same topic. I mean, what can be done to mitigate the hesitancy that's out there? And I was also hoping you could talk about the role of the advisory panels, such as Verpac and ACIP at the CDC. Give us a little more sense of what those bodies do, and is their presence something that could help convince the public of the ultimate safety, I guess, of the vaccine?
Yeah. So thank you, Chris. So first of all, I just want to say that I completely agree with everything that my distinguished panelists have said with respect to vaccine hesitancy. One additional point that I wanted to make about it, because I think I'm essentially an optimist at heart, is that I would say that we have before us a national and a global teachable moment when it comes to vaccines. That could stand us in good stead, not only for COVID-19 vaccines, but for vaccines in general, vaccine uptake, and diminishing vaccine hesitancy. Because we develop, regulate, and deploy vaccines many times over, but we don't generally do it on center stage. And so this is a time when we can really educate the public. And I wanted to amplify something that Lisa talked quite a bit about in terms of trusted messengers, and to say to you, Chris, that I actually think that the partnership with the media as a potential trusted messenger to then inform people in the community is critical. I always point, for example, to the New York Times Vaccine Tracker as an extraordinary source of information for everyone. And I think that if we do this right, we could not only increase confidence in COVID-19 vaccines, but increase confidence in all of the vaccines that we deploy. So as for the role of Verpac and ACIP, maybe I can just start out to clarify that both of these are advisory committees. They don't make policy, they advise government agencies on policy. So Verpac advises the FDA on vaccine licensure, and will, in this case, in the case of COVID-19, if a vaccine comes for emergency use authorization, the recent guidance from the FDA has indicated that Verpac will also advise at the FDA on emergency use authorization. ACIP advises the CDC on vaccine use. How should the vaccines be deployed? In the case of COVID-19 vaccines, perhaps which group should be prioritized. These advisory committees, both of them, are made up of independent experts. They are often people like me from an academic setting. They can be also from a public health setting. And they are vetted to be free of conflicts of interest. These are people who, at least in my case, think of it as real public service. They do this because they want to contribute. And I think that their involvement should really increase confidence by the public that these agencies, which themselves are staffed with really dedicated, committed, expert professionals, are also being advised by this independent group of experts. And I will just end by mentioning that if people are interested, all of these committees' deliberations are open to the public, and Verpac will be listening to general information and giving opinions on COVID-19 vaccines in general on October 22nd. And people may want to tune into that.
Okay, so thank you very much. And as for your pitch to have people pay attention to the media, I would love it if everybody paid attention to us, but our trust levels are pretty low right now as well. So let me just ask one final question that deals with hesitancy issues, and then we'll start to take questions from our audience. I'm just going to throw it to all four of you. does anybody have a sense of the people who are hesitant out there? How many of them are just kind of hesitant or scared versus those who are, hardcore anti-vaxxers who won't want to take a vaccine, in any circumstances? Do we know of the hesitant, what percentage are persuadable and what percentage aren't?
I can go first.
Sure.
Thank you. Here's the way I would respond to that. In my role as state health commissioner, we had the same. There was an appearance of that there was a lot of people who weren't going to take the vaccine for all kinds of reasons. And when we put in a process in place, actually, to understand that, we didn't see a lot of people who are by core just anti-vaccine. We saw a lot of people who were more hesitant. And it turns out that obviously if you are at the core just anti any vaccine, then you would want your appearance, especially if it's not a large appearance, to look large. You look like a movement. And they're often funded by the same way some organization, others that rather stay under the covers. But we need to speak for majority of Americans, and majority of Americans both have a right to know the process, right to know and understand from a regulatory manufacturing sense, but also learn more about this particular and other vaccines, because we know why we have some decline in vaccine. Generally speaking, Americans do take up childhood vaccination for a number of vaccine preventable disease. Really, that's the reason we've been able to eliminate many of these diseases, and for others, we've had literally zero or near zero cases for a long time. So, and when outbreaks do happen, they happen also more frequently in areas where people haven't taken the vaccine. So we know that's the case. We also know, though, that the populations who are suffering the most right now from COVID, meaning, as Lisa mentioned, higher proportion of hospitalization and deaths, African Americans, the Latinx population, are also the population who are expressing the most concern about the vaccine. And we have to be really careful and understand, both from a communication standpoint, but also understand, as Lisa mentioned, we need to get to have trusted messengers. First, the message has to be trustworthy, and then messengers have to be trusting in order to understand, because we've had some sordid past history in this nation of having interventions done in populations. So we have to be careful about that. The last point I'll make very quickly is this. Make no mistake about it. We have not succeeded, whether it's the mask wearing, whether it's the social distancing and other precautions. So if we continue the same path by having have the experts say one thing and politicians say just the opposite, and our leaders not really adhere to any principles, we're going to end up in the same category that we are now. No vaccine can immunize us against the disease in terms of if we continue on the same path. So there's going to be, I don't want us for a minute to think that we're on the right path and we just need to make adjustments. We have to make some major changes to the way we're approaching this pandemic in our nation. Otherwise, it may not be far where other countries may actually accept. There's a lot of data showing there's a number of areas of countries, especially in Southeast Asia, that are much more amenable and friendly to a vaccine per se from data. Now, we may have a bifurcated world in a few months where United States and some of Western European countries continue to suffer while the rest of the world has immunized itself. Okay.
So it's a little after 11. I wanted to get to some viewer questions. We have just about 21 minutes left. So when I'm asking you questions, I'll try to direct it to one person. Try to think in terms of 1 or 2 minute answers so we can get through as many questions as possible. This one from one of our listeners or viewers, I think I got to direct it to Paul. Could you maybe just give me a sense of the timeline for when a vaccine would be available? And might we have a vaccine before the end of the year? So can I guess give us the best guess as to how this will play out time-wise?
Okay, so the figures that you would have heard of from the very beginning, Dr. Fauci, would be 12 to 18 months. Remember, in the introductory remarks, mumps took 4 years, and we still don't have an HIV vaccine. So vaccines are not fast. The process will run. And for example, this week, again, speaking back to vaccine hesitancy, I've had many discussions about the pauses in the clinical trials, for example, with J&J and AZ. Those things are necessary parts of the development process, and they will happen. That will, by the very nature of a pause, slow things down. So optimistically, I would say it would be wonderful if we can license something this year, early next year. But remember what I said in my presentation, it's really only a vaccine whenever it's licensed, and it's actually really not a vaccine until there's hundreds of millions of doses that can be used. So there's the manufacturer, there's the distribution, and there's the getting the vaccines out there, and that all collectively takes time. Yes, we are doing it fast, but absolutely we are not rushing. And I think it's very important for the individuals who are hearing this to not equate warp speed with rush. There's connotations of that. And again, we've talked about leadership. Leadership uses imprecise terminology, then we end up with people being concerned and people thinking it's being done fast, it's being done rushed, and rush equates to not safe. So those are all of the tensions in terms of the time. Vaccines should be licensed when they've gone through the process, they're shown to be safe. That will lead to people using them, trusting them.
So let me ask this as a quick side question. You mentioned warp speed. How many of the 4 panelists think that warp speed is a good name to give this public effort? I mean, does anybody have thoughts about you like the name or you don't like that name?
Well, I just answered, so I'll quickly answer and leave it then to the rest of my panel colleagues to expand, but I will answer quite simply, no.
No. How about you, Lisa or Ruth or Rahul?
With all sort of communication types of messages and strategies, what we say matters and how we say it matters. And so when there are already historical concerns about vaccines and studies and that sort of thing, then I think the last thing that the public probably wants to hear is a perception of something being rushed. And so that's why it's so important to communicate often, early, frequently, what we know, exactly what's happening, so that the public understands that the process for the development of these vaccines is going to be a safe and appropriate process, and which doesn't necessarily align with sort of the terminology that is currently being used.
Okay. So let me get on to another question. I think I'll toss this one to Ruth, although if one of the other panelists wants to weigh in, that'd be okay. This question is from Vera Donnenberg from the University of Pittsburgh Medical Center's Hillman Cancer Center. It's about SARS-CoV-2 efficacy. A recent article in The Lancet described an investigation of 2 instances of SARS-CoV-2 infection in the same person, suggesting that previous exposure may not have guaranteed protective immunity. This is a second known case of reinfection. How will vaccine manufacturers assure long-term efficacy of their vaccines? And should human challenge trials for SARS-CoV-2 vaccine development be incorporated into phase 3 testing? Ruth, is that one you can handle?
Oh, yes.
Okay.
Thank you. So I'd like to say a few things about this, and I come at this as both a respiratory virologist and a clinical investigator. So first, with respect to reinfection, it is not surprising to those of us who work on respiratory viruses that reinfections with this virus take place. nor do I personally expect that any COVID-19 vaccine will absolutely protect against reinfection. That is, give you sterilizing immunity. The purpose of these vaccines is really to prevent severe COVID disease. So we could certainly expect that people might be reinfected and have mild symptoms. And I would consider that myself a perfectly acceptable outcome. As for human challenge studies, I know this is a very controversial topic. I remain firmly opposed to them for a number of reasons. The first of these is that I'm actually really opposed on both scientific and ethical grounds. From a scientific perspective, we're trying to protect first vulnerable populations and then other populations. We're talking about doing human challenge studies in young, healthy adults, and there's no guarantee that what we see in that population will then translate, for example, to older adults or adults with pre-existing conditions. The second ethical issue is, with every passing month, we learn more about the long-term effects, both the long-term effects of infection with this virus and the unexpected complications, even in very young people. And I think that given that we have absolutely no readily available medical countermeasure, we do have remdesivir, it does have to be given intravenously. I personally think it is unethical to contemplate human challenge trials at this time. Thanks.
Okay, so let me toss a question to a question from Suwait Nair of Georgetown University. This is for Dr. Gupta. When you were describing the different phases of supplying vaccines to Americans, you mentioned in the second supply phase that the homeless and underserved should be provided vaccines. Would you say that migrants and refugees within the United States fall within this category of the underserved? And beyond Rahul, any other panelist who wants to talk about how should the health of migrants and refugees be prioritized in the supply of vaccines, both in the US and globally? So Rahul, if you could tackle that, I guess.
Thank you. Yes, it's really important. One of the populations that we often underlook and undercare for a variety of reasons, not just socioeconomically, but also the legal status, and are really exploited. I do think that that's a population that needs to be covered in that category in phase 2. And I do think that it's important to recognize that ahead of time and include that. It is a very, very important population, and that includes those children and others that we may have in camps on the border. That's also very important, and other folks within that same category.
Okay. Does anybody else have thoughts they want to share about how refugee or immigrant populations, both in the US and around the world, should be handled? Lisa?
Yeah, I would just add to that I agree with Dr. Gupta, particularly given, again, the social conditions and environments in which these population groups tend to live in. And we know that in and of itself makes them exceedingly more vulnerable to the virus. And so given the challenges of really in any sort of rapid way addressing many of those conditions in which the individuals are living and their families, then to ensure that they have access to a vaccine to protect them, I think is appropriate.
Okay, so let me, this question, it's from Adrian McKinney at Texas Children's Health Plan. Rahul Gupta discussed the priority of populations to receive vaccines, and he mentioned essential workers. What is the plan or recommendations for essential workers who do not want to receive the vaccine in the first phases? So Dr. Rahul, could you maybe tackle that one?
Yeah, thanks. And I'll just caveat this. These are some of the recommendations initially of the National Academies, and hopefully that the recommendations from scientific advisory committees such as Acip would look at these seriously. We always have a level of population that are frontline workers, healthcare and high priority workers who choose not to for a variety of reasons. The way we have done with that and handled that with the flu, for example, flu vaccine is several of the hospitals and more increasing number of hospitals and health providers have decided to make it a policy, a worker policy, that you will have the vaccine unless there's a really good medical reason not to. So that's one way to approach it. The other could be wearing a mask and other aspects. But remember, this is an area, it's very important. It's not just for you as a person, it's also to protect you and to protect other vulnerable populations that you're coming across with. So if you are an EMS personnel and you have to run, you have to do your shift, it's almost impossible to be able to do the shift if you're in the incubation period and potentially a transmitter of an infection from COVID. So it becomes very important to understand this is not only to protect you, but also to protect the people who we have promised and taken an oath to serve.
Okay, thank you very much. So I got a question for Ruth here. This is from John Abramson at Wake Forest Baptist Health Brenner Children's Hospital. And this is for Ruth, as I said. Despite a growing consensus that pregnant women should be included in studies of new vaccines for use in infectious disease outbreaks and pandemics, pregnant women have not yet been included in any of the phase 3 studies of COVID-19 vaccines. How do we break through this barrier to make sure that pregnant women are included during phase 3 studies rather than waiting until phase 4 studies?
Yes, so thank you very much for that question, John. What I would say is that we do have to think carefully about this, about how pregnant women, for all of the reasons that I mentioned, how we care for pregnant women in this pandemic. A few important things just to mention. One is that we are mostly working with novel vaccine platforms, whether these are brand new vaccines like mRNA vaccines or subunit vaccines with novel adjuvants or adenovirus vectored vaccines. They're all relatively new. I think there's a consensus opinion, at least among people that I've talked to, and I tend to agree, that rather than including pregnant women in ongoing phase 3 trials, which are large and which are done carefully, but not necessarily by people who have clinical investigators who have experience in working with pregnant populations, that it might be best to consider phase 2 trials done in parallel by experienced obstetricians and gynecologists, maternal fetal medicine specialists, thinking particularly about individual platforms and their suitability for pregnancy, and having those clinical investigators with experience with these populations who can very carefully and thoughtfully oversee these trials. So that's how I would see it evolving.
Okay. So we have just 6 or 7 more minutes. I'd like to get a handful of questions in. So I'll try to find some that lend themselves to fairly quick responses, although that's often difficult. This one is from Ruth Yaher. In the 1950s, I was a guinea pig in Dr. Jonas Salk's polio vaccine trials. I didn't know until this morning when I listened to his son, Dr. Peter Salk, that there were companies that didn't follow all the procedures, and as a result, people got polio from the vaccine. As a patient, how can I be sure that the vaccine I would get would be safe and that the manufacturer would have followed all the proper procedures? So this is another question about trust in the manufacturing process. Paul, could you maybe tackle that one?
Again, I've already mentioned the news that you would have seen this week about the pause in the clinical trials. Those pauses are part of the process to ensure that the trials are not continuing if there are adverse events. So hardwired into the development process in the trials, we have these pauses and also holds. And the reason why you're hearing about that is because really these vaccines are being developed under a global microscope. So everyone's watching. These types of things happen all the time in clinical trials, but no one talks about it. Why is that? Because it's not coronavirus, it's not a pandemic. So I think that it's important to talk about trusting the process, ensuring that what was done in the past is being done in the present. And there really isn't any advantage in rushing a vaccine, licensing something which was unsafe, because as you've learned today, as we've talked, vaccines have done so much. None of the individuals in this call, none of the individuals in the organizations that are represented on this call and right across the country would want to, in any shape or form, undermine the word vaccine. So vaccines matter, vaccines work, and integral to the development process is safety, safety, safety.
Okay, so time for a couple more questions. I'll just toss this out to the full panel. This is from Barbara Ashford at Piedmont Natural Gas. Could the panel discuss costs for recipients associated with distribution if and when a vaccine is developed and mass produced? So from the user's perspective, how are the costs of this going to be covered? Ruth, you want to handle that?
Just to say that I believe the policy suggested by the national academies is that these vaccines be free. I have heard that from other additional sources, and my colleagues may want to comment, but that, as I understand it, that is the plan.
Yeah, I'll just mention, as with H1N1, the vaccines, we strongly would recommend it. I think all my panelists, as well as national academies, have already be free. The issue becomes one of the administration cost. That's one that we must make sure that insurers, including Medicare and Medicaid, are reimbursing a reasonable administration cost. Regardless of, we have to figure out for those who are uninsured, actually are able to bear that cost. So for those who are uninsured, there should be, at the end of the day, no cost to the person who's receiving the vaccine, and your insurance status should not matter. So for those who do not have insurance, there should be an ability to be able to bill back and account for those funds through some grant and other mechanisms of programs. But at the end of the day, person should not have a cost, but that's where having insurance, having access to insurance, all those factors come into play, including the laws of the land that allow you to have insurance and the risks that we have of losing our insurance at the end of the day. People will have a risk of not getting the vaccine as well.
Okay, so we just have time for 2 questions. So I'd ask, I'm going to go to Lisa for this this first one and try to keep the answer fairly short. This is from Marissa Nye of Polio Community College in Massachusetts. Considering the barriers to receiving the vaccine that Dr. Waddell has discussed and the stages of distribution that Dr. Gupta discussed, what would you say to those who argue that we should not be opening schools to in-person learning until a vaccine is available?
Well, there are many recommendations and guidance around schools, whether they're K through 12 or whether it's through institutions of higher education, and certainly important data that varies from communities to states. And so there are important recommendations that administrators, along with community leaders and public health officials, are all looking at together to make these very complex decisions. And so with, again, this is an example of when we can all be part of the solution and on the right side of history by working together to make sure that we're all washing our hands, that we're wearing a mask, that we are staying home if we're sick, and that we're using all of those precautions that are available to us now so that our young people can get the education in the environment that best meets their needs and in the context of the decisions that are being made with their families, teachers, and communities.
Okay, so final question here. It will maybe allow us to go out on an optimistic, happy note. This is from Carl Kurlander at the University of Pittsburgh. The Salk polio vaccine was truly a collaborative effort. Jonas Salk famously did not patent the vaccine and said it would be like, quote, patenting the sun. It belonged to the people. That was after World War II, and we were united. Today, we are a divided country in many ways. Do the panelists see a way for us to come together again, and what could help us all remember what we can achieve when we all unite against a common unseen enemy? So that's a big question. We have a little amount of time, so I'm gonna toss that to Ruth. Could you tackle that one?
So I think we're already there. You know, I'd like to hearken back to something Paul said in some of his introductory remarks. We have collectively rolled up our sleeves for this problem. It's really remarkable to me how scientists in academia and biotech and big pharma nationally, globally, have worked together, have shared data, have made vaccines in record time. I think we could think about warp speed as time to develop the vaccine, not time to evaluate necessarily. We're careful about that. And also to the many volunteers who've rolled up their sleeves to be part of these studies. So I think we're already there.
Okay, so thank you for that. That's a good way to end this panel discussion. I want to thank all four of my panelists, Paul, Rahul, Ruth, and Lisa. And now we're going to introduce a final speaker of the day. Dr. Anantha Shaker is the Senior Vice Chancellor for the Health Sciences and the John and Gertrude Peterson Dean of the School of Medicine at the University of Pittsburgh. He's a nationally recognized educator, researcher, and entrepreneur with major contributions in medicine and life sciences. He joined the University of Pittsburgh in June 2020 after 3 decades at the Indiana University School of Medicine and Indiana University Health. And Dr. Shaker has some closing remarks for us, and I'll turn the floor over to you.
Thank you, Chris, and thank you, everyone, for this wonderful panel and the distinguished guests on this panel. Particularly also thankful to the Wilson Center for really sponsoring this, hosting this program, along with March of Dimes that has supported this. I think this is really a historic moment in our world, in human history, in fact, and in modern medicine for sure. And it is really gratifying to see that the history of Pittsburgh is now potentially repeating itself in a much bigger scale and in a much more, I would say, pressured situation. Polio was such a pandemic and was such a killer. And Dr. Salk's work, as has been described, was part of that solution. And much has changed too in the world in terms of science. And as Paul was describing, the whole field of virology, vaccinology has advanced so much since the time of Dr. Salk. But yet the same principles are still challenging us. The fact that virus it presents itself with variety of host-related issues that are that could be anywhere from mild symptomatic to totally lethal is still prevalent. And in fact, that's been one of the big challenges with COVID-19. The fact that there is concerns about safety of the vaccine or the process of production of the vaccine, the distribution, even IP for a vaccine are still major challenges. We had, as someone mentioned in the question and from the panel, a much more united world then, that people from Professor Salk, who essentially did not patent the vaccine, all the way to people who contributed to the distribution and production of this vaccine were dedicated to making sure that everyone got the vaccine. In fact, just a brief history here, Dr. Salk's team was very diverse. It had women, it had minorities, it had a number of representatives of what we would today call a team, the diverse team. Obviously, they were very motivated by philanthropy, particularly March of Dimes, which actually partnered with them and supported the initial trials in the Pittsburgh school system. So children in Pittsburgh schools were the first group that got the vaccine, including, I believe, maybe Professor Peter Salk himself as one of the people during that time. So there was a lot of local pride and local engagement and diversity involved. One of the concerns during the historical discussions were, how do we make sure that children of color accept and get this vaccine? So imagine, in 1950s, they were struggling with that same social and challenges that today we still are. In fact, we may have exacerbated that with our health disparities. So these historical factors are still present today, and we should be really much more enlightened. What has changed on the positive side is that now there's extraordinary commitment and coordination and cooperation across the globe. As you can imagine, even as fast as we can do science today, the virus was sequenced very quickly. The Shanghai Institute put out the structure of the virus on January 10th. And today in October, we have, as has been said, over 160 vaccine candidates being tried. Because there's global cooperation, because there's scientific sharing of information, a lot of companies are now doing very careful studies. The idea that some of these highly anticipated vaccines or trials are being slowed or halted means that science is actually holding court and preventing people from rushing things that aren't ready yet. So I see that as our processes are in place, our science is good and is global and can deliver. The big challenge, of course, is trust in science, which has been eroded, unfortunately. Trust in facts, which has been eroded. Trust in truth, which has been eroded. All of these challenges have to be, in fact, addressed before we can successfully make sure that there is a acceptable vaccine and that we have answers for vaccine hesitancy. The other challenge, I think, is affordability and logistics of production and distribution. And this is where the global governments and global health authorities are coming together, but it is going to take a leadership, particularly leadership from the United States and leadership from the developed countries, to make sure that we don't essentially create a splintered world, as Dr. Gupta was mentioning. So I think there's a lot of great opportunities. There's a lot of optimism. I'm one of the people that is quite optimistic and feel like the world will be a better place in 2021, definitely by 2022. And I'm very proud that Pittsburgh historically and in the current day will be a great contributor to this outcome. So thank you again for this wonderful event. Thanks to all the panelists for this great discussion. And I look forward to having the same conversation a year from now with hopefully very positive news from the world.
All right, thank you very much. And I want to thank the audience, and I'd like to thank the Wilson Center and each of our panelists. The event recording from this will be available on the Wilson Center event page within 24 hours. A summary of today's events will be published on the Wilson Center's blog, New Security Beat. So thanks again to the speakers, to Paul, Lisa, Rahul, and Ruth, and to Peter Salk and to Dr. Shankar, as well as the Wilson Center, the March of Dimes, the University of Pittsburgh, and the Jonas Salk Legacy Foundation for their support and collaboration on this. And thanks again to the viewers for tuning in, and all of you stay healthy. Thank you very much.
Thank you.